Welcome to our webinar titled Advances in Treating PNH. Thank you for joining us. My name is Lee Clark, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our specialists cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Eloy Roman. Dr. Roman is a hematologist-oncologist in Miami Lakes, Florida. He graduated from medical school in 1999 and has over 2 decades experience in the medical field. Dr. Roman is part of Lakes Research, which is a multi-specialty physician group with headquarters located in Miami Lakes, Florida. The group is dedicated to patient safety and providing quality research and protocol adherence. Welcome, Dr. Roman. Thank you so much for joining us today.
Hi, it's my pleasure. Good afternoon, at least on the East Coast. So I hope everybody's doing well. My name is Dr. Roman. I'm a hematologist-oncologist, as they've already mentioned, in the Miami Lakes area. And today I have the pleasure to speak to you about paroxysmal nocturnal hemoglobinuria. So the first thing I want to say is I want to make this fun. I encourage questions at the end. I'd love to be able to help anybody who feels that they have a question and wants that to be answered, and I'll do my best to answer that question, and hopefully it would give you, it would be beneficial for you, and I'd be able to help you out in any way I can. So I'm going to try to keep it simple because I believe that this should not be complicated. And there is a lot of information, but it's really not difficult when you come to when you put it all together. This is sort of a puzzle. So here we go. The first thing I want to say is if you look at this name, paroxysmal nocturnal hemoglobinuria, kind of scares you because the first thing you say is, wow, what a name. And I kind of love it because when people ask me, well, what type of diseases do you treat? And I say, well, I treat paroxysmal nocturnal hemoglobinuria. The first thing is people think is, wow, this guy's a genius. So I tend to like that name. But in reality, the name is a misnomer because paroxysmal, it's really not paroxysmal, meaning coming and going. No, this is a constant disease. Some people get it a little more severe than others. It's not necessarily nocturnal because when you read something nocturnal, you think, okay, this is only active at night, and that's not true. It's active all the time. It could be during the day, it could be at night. So that's also not appropriate if you think about it. And hemoglobinuria, which is free hemoglobin in your urine, and that's what causes the dark urine, only occurs in about a quarter of patients. So the majority of people are not going to have dark urine. So, if you think about it, the name is not completely appropriate, but we're not going to be changing the name, at least not today. So for now, it is called PNH, and that's what we're going to be speaking about. So let's dive into this disorder. So what is PNH? So the next few slides, I believe you'll be able to grasp exactly what is happening in PNH. So first of all, this is an acquired red blood cell defect, and it is a stem cell disorder. So basically, in your bone marrow, you have stem cells, and these stem cells make, your mother cells, also called blasts. Again, a lot of these cells have different names, but it's the same cell. So you have the PIGA gene, which encodes or basically is in charge of making special proteins in your body. And I will illustrate this in the next few slides, pictures, so you can grasp this. So basically, you have a mutation. What's causing PNH is you have a mutation in the PIGA gene, okay? So that's where the defect is, the problem. It affects about 1,500 to 5,000 people in the United States. And as time goes on and diagnosis, which has gotten a lot better, we've identified more patients. So it's no surprise that the more we know about it, the more we think about it, the more patients we find. The median age is about the mid-30s, although we do see it in patients that are younger and in people that are much older. And it also, unfortunately, when you have this disease, as a lot of you may already know, it does affect your quality of life. Okay, you have a lot of symptoms, fatigue being one of them, and then a bunch of other findings, namely thrombosis, which is basically blood clots, which can cause a lot of issues in your body. And we're going to dig deeper in the next few slides so that you'll understand pretty much what's going on in this illness. But the most important point in this slide is what's causing the disease is you have a mutation in the PIGA gene. So that's where the defect is. So the complement system. So our immune system has several components. If you think of your immune system as what's fighting off infection, you have your white blood cells, and within your white blood cells, you have several other types of white cells. It's subdivided into your neutrophils, your basophils, your eosinophils. There's a bunch of them. Well, you also have this system, which is called the complement system. And basically, this is in charge of several important functions in our body. And there are several different pathways, the lectin, the classical, the alternative. And basically, the function is you want to turn these proteins on. So here you see you have C3, okay, then you have C5 down here. Basically, when it's needed, C3 is activated, which it's usually always active. And then C3 goes on and turns on C5, and then C5 breaks up into C5a, C5b, and each one of these has several functions in your immune system. So if you have a defect in any one of these, right, overall, you may have a higher risk of an infection because this is part of your immune system. So just know that each one of these parts has important functions within your immune system. So this is the complement system, okay? It is a complicated system. It's a bunch of proteins that basically help fight off infection. If you see here, it helps fight off infection. It has to do with inflammation, with microbial opsonization, which is basically your body's ability to pick up bacteria and get rid of them in the liver, in the spleen. I mean, it's a very complex, complicated part of our immune system. And then the complement system is central to what's causing your problem in PNH. And we'll go over that in the next few slides. So remember we said that when you have an abnormal, the defect in your PIGA gene, right? This mutation or this defect causes your body to not be able to produce a specific protein. So I want you to see this depiction or this picture here. So here you have, this is the cell surface. And then in blue, you have your GPI anchor. And here you have CD55 and CD59. So Of course, this is amplified. This is under a very specific microscope, if you will, and you're looking at the cell. So this is normal. You have the cell surface, you have the GPI anchor, and you have the CD protein on top. Now, if your complement system, which was the prior slide, if this part of your immune system was to be hanging around the area, it cannot destroy your cell because these proteins are protecting your cell. Now, if you have an abnormal PIGA gene, your body cannot make this GPI anchor. So these GPI anchors are missing. And if the GPI anchor is missing, of course, this protein, CD55 and CD59, are also missing. Now, this cell surface layer is exposed, and your immune system, the complement system, can attack it. And that's exactly what happens in PNH. You are missing this GPI anchor, so your cells are exposed to immunological attack by your complement system. And this is exactly what happens. So right here, you see that your complement system, this is your cell surface. Your complement system literally punches holes in your cells, many little tiny holes. And then through osmosis, let's just keep it simple. Water will go inside your cell, and your cell will swell up like a balloon, and it'll pop. And when those cells break, or your red blood cells break, that's what's called hemolysis. So when you look, this is under an electron microscope. Look at all these tiny little holes. Again, the GPI anchor is missing, and the cell surface is unprotected. Complement literally comes and opens all these little holes. And if you can imagine, that red blood cell is going to swell up and it's going to pop. And then when that happens, your hemoglobin goes down because that is hemolysis. And then your LDH, which is a blood marker, will go up. Haptoglobin, which is another blood marker, will go down. Those are the indicators that you have hemolysis going on. And then, unfortunately, that anemia that's going to result from the hemolysis is going to give you symptoms. You're going to feel the weakness, the fatigue. That's also going to cause a whole bunch of other issues inside your body. If you imagine your cells are missing these proteins that can protect it and prevent complement damage on your endothelial lining inside your blood vessels, that's also going to cause inflammation. That inflammation can cause the blood clots. I mean, it's not one thing that's happening. It's a whole cascade of events that's happening at the same time. Some people may have it a little more severe than others, but you can imagine the havoc that this complement system is causing on your body because you are missing this protection from your GPI anchor. So it's a simple concept, but when you think about it, every patient is different because they all present in different ways and they all can have different levels of disease. So as a recap, complement successfully attacks your red blood cells and they break up. And this is called hemolysis. That's when your red blood cells pop. Red blood cells are destroyed, resulting in anemia, which we mentioned. So your hemoglobin now is going to go down. Remember that the primary function of your red blood cells is to carry oxygen, and oxygen is carried on hemoglobin. So if your red blood cells break up, your hemoglobin is no longer, it's not carried by your red blood cells anymore. So it's released into the blood. So when you get a lot of hemoglobin in your blood, your kidneys try to get rid of it, and that is where you get hemoglobinuria. That's what gives you the dark urine. But in order for that to happen, you have to have a significant amount of hemoglobin in your blood. So if you don't have that much at that specific time, then you may not get the dark urine. And that's why the majority of patients don't get the dark urine, or they'll get it one time and then maybe for several months, they won't see another episode of dark urine. So you got to be careful and not just rely on that dark urine. Then that free hemoglobin binds to nitric oxide, which is found in the body. Now let's stop here a minute. Nitric oxide has several functions. one of them being smooth muscle relaxation. It has to do with your smooth muscles need nitric oxide in order for them to function normally. Now, that free hemoglobin that's in your body eats up, it binds to and gets rid of nitric oxide levels. And this is why many patients with PNH get the esophageal spasms, the abdominal pain, erectile dysfunction, because your body needs nitric oxide in order for the smooth muscle to relax. And then you get spasms. If you get spasms of the blood vessels in your stomach, you can get the abdominal pain. The erectile dysfunction results again from the absence of nitric oxide levels, which you need in order for that not to happen. So if you can imagine, this is why all patients with PNH present in such different ways, because it really depends how much free hemoglobin is going around. Do they have potential triggers that is provoking or worsening the PNH? For example, if you have an infection, that tends to increase your immune system. So if your immune system, remember we said the complement system is part of your immune system. And if your immune system has been activated because of this infection, it can make these symptoms worse. It can worsen the PNH symptoms, at least until that infection resolves. And those are called triggers. So hemoglobin, as we said, is cleared by the kidneys and then often resulting in that dark urine or wine-colored urine, dark red type urine. It can look like blood. It can look like Coca-Cola. I've heard different patients tell me different things. So I may sound redundant, but I believe that as humans, we learn through repetition. So I tend to like to repeat things a few times just to make sure that the audience is grasping what I'm saying. So this is looking at it another way, but the same information. Let me go forward here. So on the left here, we can see this is a normal red blood cell. See the normal red blood cell here in blue, the little triangles are hard to see. That's our anchor. And in green, we have our cell surface proteins that are protecting our red cells against complement. See, this is normal. Now, when you're missing those anchors and those proteins, we no longer have a protected red cell. See, these are protected, the one on the right and the left. The one in the middle is not protected. So that's the one that breaks. And then when that one pops, or hemolysis, again, the medical term hemolysis, that's what leads to all the issues that we've described. So I'm going to go one by one here, and then later on, we'll go into a little more detail. Thrombosis, which is simply blood clots. That happens because of many things. One of the main reasons, for example, is the damage that it causes your blood vessels. So that can cause hemolysis. If you think about it, all this hemoglobin is free in your blood, and your kidneys try to get rid of all these toxins that you have in your blood. So all of a sudden, you have all this free hemoglobin and all these radical formation in your body, and your kidneys are trying to get rid of it, so it can literally clump up your kidneys and cause renal failure. Doesn't happen on all patients, but it can happen in a good number of patients. Also, the lack of nitric oxide. Remember, we said you need nitric oxide in order for your smooth muscles to function. Our blood vessels have smooth muscles. So if your blood vessels are not relaxing, especially in your lungs, you can get pulmonary hypertension. So that's why pulmonary hypertension is another finding, which is basically an increase in the same way as you can get high blood pressure or hypertension in your body, your lungs can also get hypertension. And this can be quite severe. So what happens is that your heart is trying to pump blood through blood vessels that don't want to relax. So your lungs suffer, your heart can suffer. And this is something that we want to try to prevent at all costs. Again, if you're lacking nitric oxide, the smooth muscle's not functioning, and that's why you get the difficulty swallowing or the abdominal pain, and we already mentioned the erectile dysfunction. Again, this is all a direct effect from the lack of nitric oxide on your smooth muscles. And again, remember, a recap, the reason you're losing nitric oxide is because it's being consumed from the free hemoglobin in your blood. And what's causing the free hemoglobin is the hemolysis. So if we could stop this hemolysis from happening, your nitric oxide levels should remain normal. And hopefully that'll prevent a lot of these things from happening. The dark urine we already mentioned, the fatigue for multiple reasons. And I have to tell you, fatigue is probably the most common complaint I get. I've diagnosed several patients with PNH. I believe I've treated about 15 now. As a hematologist, having experience with about 15 PNH patients is quite a bit. I mean, the majority of hematologists maybe have seen one or two at most their entire career. And I believe I'm somewhere in the middle of my career, and I've already dealt with or treat at least 15 PNH patients, or have treated. So, and fatigue is by far the main symptom or finding or complaints that patients have. And I can tell you, unfortunately, some of these patients have such severe fatigue that they just can't function. I mean, it's something that it's astonishing the way that they present to you, and it's something that I really feel bad, and that's why I'm so passionate in this disease, because I believe that we can make a difference. And I'll just tell you, I've had patients tell me that they're so fatigued and they were undiagnosed that they were divorced. Their children barely wanted to see them because they were labeled as being lazy. I mean, you imagine having an illness where people are putting these labels on you, and all along you just had an undiagnosed illness. I mean, it's very sad when you think about it. And I feel glad that in some cases we've been able to diagnose these patients and we've literally turned their lives around. And it is so rewarding to have that happen. So, just wanted to let you know that maybe some of you have experienced this and can absolutely relate to this. And the anemia, again, results from the hemolysis causing anemia. And this also, if you think about it, if your hemoglobin is lower, you have less oxygen carrying capacity, and this leads to symptoms. So if you believe that a person may have PNH, how do we diagnose them? Well, the good news is we have very good tests. So the first thing is it's a simple blood test. So, all we need to do is a little prick in the arm. We take blood in a test tube and we test it to see if you have the CD55-59 protein. There are others, but remember I showed you those, the CD55-59 protein on the top. Or we have another test that's called FLAIR, where we can actually look for the anchor. Remember that on the red cell surface, you have the anchor, and the CD protein is attached to the anchor. So if you're missing the CD protein, the CD55-59, or the anchor, then you are diagnosed with having PNH. So it's a simple blood test, and the clone size, you may hear patients given a clone size. So if you have PNH, you will have a clone size, and the higher the clone size just means the percentage of cells missing the GPI anchored proteins. So the more cells you have that are missing this GPI anchor or CD55-59 protein, the higher your clone size is going to be. Sometimes we will do a bone marrow biopsy because PNH can be associated with aplastic anemia, which is basically your bone marrow is wiped out. The precursor cells that make your red blood cells, that make your white blood cells, that make your platelets is abnormal. It's either missing or partially missing. So when you look at the bone marrow, it looks like an empty bone marrow. And that's given the diagnosis of an aplastic anemia. Okay, it's basically, it's a wiped out bone marrow. We can also find another disorder, which has another fancy name. Remember, us hematologists, we like to sound intelligent. So we put these fancy names to things, and that's called the myelodysplastic syndrome. And sometimes you'll have patients who have a myelodysplastic syndrome and also have PNH. So all that a myelodysplastic syndrome is a dysfunctional bone marrow. When you look at a bone marrow under the microscope and it looks abnormal, it looks aged, the cells don't look normal. That's when we give that's when we make the diagnosis of a myelodysplasia, just meaning it looks abnormal. So where in an aplastic anemia overall, it's an empty bone marrow. In a myelodysplastic syndrome, it's just an abnormal bone marrow. Okay, and that's the difference. And a lot of times in patients with PNH, you can have a myelodysplastic syndrome, or you may have aplastic anemia, and sometimes you don't have either. You just have PNH with a normal appearing bone marrow. So just because I want to make sure that you understand that just because you have PNH does not mean that you have a myelodysplastic syndrome or an aplastic anemia, and vice versa. Just because you have aplastic anemia or a myelodysplastic syndrome does not mean you have PNH. All right, so this is basically another recap. So the thrombosis, which can be anywhere, and I want to take time now to say that blood clots is the #1 cause of death in PNH. And it can happen in our venous system or in our arterial system. So in the artery, for example, would be a heart attack or a stroke or a mesenteric arterial thrombosis. Arterial clots overall tend to be more serious. They're more deadly, if you will. Luckily, the majority of the times, the blood clots are in our venous system, but these can also be very dangerous. For example, if you get one in the lung, known as a pulmonary embolism, that can be very dangerous. And if you get a blood clot in your liver, in your the veins of your arms, in your brain, these are also quite serious. So overall thrombosis, we want to try to diagnose patients as early as possible, start them on treatment as early as possible. And the most important thing is preventing blood clots from happening in the first place. PNH is a systemic disease. It attacks our entire body, and you can have end organ damage. Again, damage of an organ. That's just what end organ damage means. Kidney damage, which we already went over. It can attack your GI tract, anywhere from your esophagus to your stomach, to your duodenum or duodenum, to your colon. I mean, you can have, think about it, you can have a blood clot to a blood vessel that supplies your colon. Or, I mean, PNH can present in many ways. So it can attack your kidneys, your GI tract, your liver, your brain. If you have anemia and the anemia is significant enough, you can require blood transfusions. A lot of PNH patients know exactly what I'm talking about with blood transfusions. And that's something that we want to try to avoid if possible. The fatigue, the shortness of breath, again, because of your smooth muscle not working well, because of your anemia, all these things resulting in the pulmonary hypertension, which we mentioned before, causing the shortness of breath. If you angina, which is basically somewhat of a lack of blood supply to your heart, either because of a clot or because of a vasoconstriction. Again, remember, your blood vessels are not relaxing normally. So that causes lack of blood flow to your heart. It can cause lack of blood flow to your intestines, causing pain. Especially some PNH patients will say, after I eat a pretty big meal, I get abdominal pain. Well, it could be when you have a big meal, you need more blood supply to be able to pick up those nutrients. And those blood vessels are not vasodilating. They're not dilating enough to get enough blood to this site. And that's causing the pain. The impaired quality of life, the fatigue, the pain. Imagine if you're in pain, if you're tired, if you're just not feeling well, of course that's going to affect your quality of life. And the smooth muscle dysfunction, which we've been over. So again, every PNH patient is unique. They're all different. And that's what makes diagnosis so difficult, because they can all present in different ways. The mortality rates in patients with PNH can be significant. So if you see here, this is in patients who do not have PNH. So in age and sex matched controls versus patients with PNH. And needless to say that if you have PNH, especially undiagnosed, untreated PNH, your mortality rate and morbidity is that much higher. That's why my passion, and I'm so, I really want to make sure that, the ultimate goal is to not have PNH patients walking around that do not know they have PNH. Every patient needs to be diagnosed so that we can appropriately treat them. So now we're going to go into blood clots a little bit more detail. So thrombosis can occur in about 40% of patients, and it can be the first finding that a patient presents. So any patient that gets a blood clot, of course, it's probably not PNH, because PNH, thank God, is not a common diagnosis. But you have to think of the possibility of PNH, especially if you have a blood clot in an unusual site. For example, a Budd-Chiari, like a liver clot. What's a normal person doing? Developing a blood clot in their liver, in their brain, not a stroke, because stroke is very common, but let's say a vein in the brain. That's very uncommon. So when you have these blood clots, especially in these unusual sites, you have to think of PNH. There are many mechanisms, there are many mechanisms which we already went over, but the exact reason as to why patients develop blood clots, we don't know. We believe it's more multifactorial, meaning there's just many reasons, some of which we've already gone over. The majority tend to be in your veins of your legs, and unfortunately, these can travel to your lungs. So in the legs or arms, it's known as a deep vein thrombosis, and if they travel to your lungs, that's known as a PE or a pulmonary embolism. We already said that they can also be arterial. So this is where your CVAs or your heart attacks, so stroke or heart attacks, can occur. And this is a big one. So if you ever see a person who has a hepatic vein thrombosis, also known as a Budd-Chiari syndrome, this is something that every time, and I think about 2 of my patients initially presented with a Budd-Chiari, and that's what led me to think, could this patient have PNH? And in those 2 cases specifically, there was a PNH clone detected. So they were diagnosed with PNH. So just remember, the hepatic vein blood clots is a big one. Again, just in another sort of a pie distribution, just the number of clots, this just shows you that the majority are veins, and thankfully the minority are arterial. To me, this is a very important slide. This is more for physicians, because I get called a lot of times for patients that have a blood clot. And, we want to know, could this person have a hereditary cause for blood clots? And there are many abnormalities in the body that can cause blood clots. For example, starting from right to left, a factor V Leiden mutation, a prothrombin gene mutation, protein C, protein S, antithrombin 3, again, fancy names. Again, you all know that us hematologists like to sound fancy. So patients can have any one of these. And these are known as hypercoagulable states or hypercoagulable conditions. Mutations that patients have that increase their chance of clotting. And the crazy thing is, we test for these all the time. But yet, if you look, what are your chances of getting a blood clot, or your relative risk of a blood clot if you have one of these conditions? Look at the low rates compared to PNH. So PNH is a significant hypercoagulable risk factor. In other words, in simple terms, a risk factor that increases your chances of having a blood clot. So I always say, if you're thinking about these, you better be thinking about this one, because this one has a much higher risk of developing a blood clot. The problem is that these are much more common. So that's why a lot of us tend to think about these and not think of PNH as much. But it should always be thought of, and you should keep it in the back of your mind. Notice that I've already said that every PNH patient is unique, and they truly are. Some of them, about 40% present with blood clots. 89% tend to present with anemia. 10 to 45% with some sort of a bone marrow failure. It could be MDS, which we already mentioned, the myelodysplastic syndrome, or the aplastic anemia, for example. Fatigue by far is the most common. And I can tell you that this is what I tend to see with my patients. So this number is absolutely accurate. The dark urine, you don't see as often. Abdominal pain, the shortness of breath, the difficulty swallowing, the ED, and the renal failure. Notice that renal failure, you tend to see in about 30% of patients, give or take. So not all patients. So patients can present with any one of these or any combination of these. And again, that's what makes diagnosis so difficult. Even though, remember we said diagnosing is simple, it's a blood test. The problem is we need to think about it. So how do we treat PNH? So historically speaking, if a patient was anemic, we would transfuse them. If they would get a blood clot, we'd thin their blood or use anticoagulants, so blood thinners. We give them folic acid. We can give them iron if they're iron deficient, although you have to be careful. Some patients with PNH tend to have iron deficiency. Some patients can have iron overload, meaning too much iron. So you really have to gauge your patient, evaluate your patient, and give them only what they need. You definitely do not want to have a patient who has too much iron and you're giving them iron supplementation. Okay, steroids. Sometimes we'd give them androgen or hormones, which, if you think about it, was kind of crazy because we now know that some hormones like testosterone or danazol or hormone replacement therapy can be somewhat hypercoagulable. We know that some of these hormones may cause blood clots, and you already know PNH can cause blood clots. So probably not the best idea, unless you have a specific reason to be giving androgen-based hormones. Steroids is a different story. The prednisones, the dexamethasone, the solumedrol, that's a different story. We use those a lot in medicine, but this is specifically more to the androgens. Now, what about a bone marrow transplant? Well, overall, there are two types of bone marrow transplant. There's an auto bone marrow transplant, meaning from yourself to you, or an allogeneic stem cell transplant, which means from another human being to yourself. So in PNH, of course, we cannot use your bone marrow because your own bone marrow is defective. So you would need to have a bone marrow transplant from another person. It could be a sibling, or it could be an unknown person that's not related to you, which is called a MUD, a match unrelated donor. The problem is that patients with PNH a lot of times already have other medical problems. They've had a blood clot, or they have renal disease, or they may have heart disease, or, so maybe a bone marrow transplant is not an easy procedure. So these patients can, sometimes it's not the case, sometimes they're very healthy, but they can have pre-existing conditions which can increase their issues with getting a transplant. Also, there's a condition known as graft versus host disease, which can be acute or chronic. And all that is when you give another person's bone marrow to a patient, that bone marrow does not recognize that person's body as theirs. Remember, it's a transplant. So sometimes that immune system that you're transplanting can attack that person's body. And that's known as graft versus host disease, where literally the immune system that you're giving that person, that new bone marrow, starts attacking that person. And if it's quite severe, it can be extremely devastating. And patients with PNH, unfortunately, tend to have overall a higher risk of graft versus host disease. So, a bone marrow transplant is not an easy thing, and it's definitely something you need to discuss with your hematologist. So now we're going to get into the specific treatment. So first of all, we have eculizumab, known as Soliris. And this is, again, our fancy complement system. Remember our complement cascade, our immune system. So remember, we have C3, which goes down activating protein, and which ultimately activates C5b through 9. And this is what's causing the hemolysis, or the red cell destruction in PNH. So what if we have an antibody, here we go, that binds to and stops C5? It blocks C5. And that's exactly what Soliris is. Soliris is a monoclonal antibody which binds tightly to C5. And now by blocking C5, you don't have these terminal, what's after C5, they disappear. And now this cannot cause disease. So if you think about it, you're kind of quieting down your complement system. And that's what almost all the treatments that we use for PNH, that's basically what it does. They quiet down our complement system, okay? And if you look here, LDH is a blood test. And when our red blood cells break, when you have hemolysis, our LDH, which stands for lactate dehydrogenase, levels tend to go up. So when we have a patient whose red blood cells are breaking, overall, you tend to see high LDH levels. So that's why maybe your hematologist, you've noticed, is always following LDH levels, because it's sort of a surrogate marker. It's a good marker if you're hemolyzing or not. So if you see your hemoglobin is going down and your LDH is going up, it means that your red blood cells are breaking, and that's not good. We don't want that to happen. So these are the clinical trials, the Triumph and the Shepherd trial for Soliris, demonstrating that as soon as they got drug, their LDH levels went down, proving that hemolysis stopped. And then patients that were on placebo, they were followed. And then once we saw that the drug was working, of course, we're not going to keep these poor patients on placebo. So we gave them treatment, and their LDH plummeted on this group as well. So this is proving that Soliris blocks hemolysis, which is what we want. Okay. What about the effects on transfusions? Well, if your hemolysis is quieted down, in other words, your red blood cells are not breaking as often, then the need for transfusions will also go down. And that's what's illustrated here. It's just common sense. What about blood clots? Again, if you're stopping the hemolysis, your nitric oxide levels are good, your smooth muscles are not constricting, they're dilating, if you remember what we spoke about before, then your incidence of blood clots also go down. And that's what's basically depicted here. So 92% fewer thrombotic events with Soliris treatment. So that's a good thing. What about Ultomiris or ravulizumab? So it's the second FDA-approved drug for PNH back in 2018, and it's also a C5 blocker. The difference is you don't have to give this drug as often. It has a longer half-life, about 4 times longer. So it's dosed every 8 weeks instead of every 2 weeks. The clinical trials show that it's at least as effective as eculizumab. And the incidence of breakthrough hemolysis events is shown to be lower. So again, here we have another drug which blocks the complement system and helps prevent hemolysis. All these drugs, I'm just going to pause here for a quick second just to say that we've been lucky, especially patients with PNH, and of course, myself included as a treating physician, that we have wonderful drugs. All the drugs that we have for PNH are wonderful. And that's my medical and professional opinion, that all of these drugs are very good. Side effects and drawbacks to the inhibitors of C5. Well, first of all, if you think about it, if you're blocking part of your immune system, right, you're blocking part of complement, what do you think is going to be a side effect? Infections. And that's why it's very important that all patients on complement inhibitors have their vaccines up to date. And the main bacteria are encapsulated bacteria. It's the same bacteria that our spleen protects us against. So I tell all patients, make sure you have your meningococcal vaccines, your pneumococcal vaccine, and your Haemophilus influenza. That's not the flu vaccine, not flu, no, Haemophilus influenza. All 3 of these are bacteria. They're all encapsulated, and make sure that your vaccines are up to date as per guidelines. Some vaccines, you have to give them every 5 years, some are every 3 years. Just make sure that whatever vaccine you are getting is kept up to date. And if you're already on one of these treatments, you know that you're already on the REMS program. So chances are that your physician is on top of you, or the pharmaceutical company a lot of times is on top of patients, because they want to make sure you're protected and that your risk for one of these infections is reduced. Now, the first line here, transient headache and fatigue. This is actually a good thing. If you think about it, all of a sudden, your body is used to having low nitric oxide levels. You give one of these drugs and your nitric oxide levels go up. Remember, nitric oxide relaxes smooth muscle. All of a sudden in your brain, those smooth muscles that have been somewhat constricted are dilating. So you get a blood rush. And that's why, or one of the proposed mechanisms that you can get headaches. Risk of hemolysis if you all of a sudden stop it. So imagine you're on these treatments and you stop this treatment cold turkey. You could potentially have a hemolytic event. Your red blood cells can start breaking up. So, just keep that in mind. So that's why if you're going to stop treatment, make sure you tell your physician, because they need to follow you closely to make sure you do not have breakthrough hemolysis. So increased C3-mediated extravascular hemolysis. So these drugs tend to work inside your blood vessels. Now, there are patients with PNH that, despite being on C5 inhibitors, the Soliris or the Ultomiris, they still have low hemoglobin levels. And that could be, one of the reasons could be that you're still having hemolysis, but outside of the blood vessel. And that's called extravascular hemolysis. So let me just explain this really quickly. If your hemolysis is happening inside of a blood vessel, that's intravascular hemolysis. If it's happening in your spleen or your liver, that is called extravascular hemolysis. Ultomiris and Soliris tend to work intravascular, not extravascular. So just know that if you have some patients that, despite being on treatment, still have requirements for blood transfusions or still have significant anemia, it could be that they're having extravascular hemolysis to a greater degree than intravascular, or they're having also, on top of intravascular, extravascular hemolysis. So just keep that in mind. Also, this disease has no cure unless you do a bone marrow transplant. We already know patients tend to have issues with bone marrow transplants. So just know that treatment tends to be lifelong. And these drugs are expensive. These drugs, it costs an awful lot of money to make these drugs. And this is not a drug that's used, it's not aspirin. Not everybody is using these drugs. So there is a certain cost to these drugs. Now we have a new drug as well. It's called pegcetacoplan or Empaveli. The only difference between the other two drugs, and there's a few differences, but one of the main differences is that instead of working on C5, it blocks C3. So a little bit further up in the complement cascade. This drug is given subcutaneously. It's not given in the vein. So the good thing about this drug is that you could potentially infuse yourself at home. You have to be trained for it. You have to know what you're doing. Again, there's pros and cons to all these drugs, all these medications. They are all very good medications. And choosing which drug is really up to you and your hematologist. As to what they believe and you believe is best for you. I know some patients that tell me, no, they rather come into the office. They don't want to be self-dosing, and that's good. I have other patients that tell me, I have a very busy schedule. I don't want to, I want to come see you as least as possible, which I don't get offended when they tell me that, by the way. And that's fine. And maybe pegcetacoplan is a better drug for them. I mean, it really depends. It's up to the patient. And Pegcetacoplan is said to work both intravascular and extravascular. So maybe you have a patient that despite treatment with a C5 blocker, the Solaris or the Ultomiris, they're still having significant anemia. You could consider having them on Empaveli instead. But as I said before, we are very lucky because all of these drugs are extremely good medications. There are other complement inhibitors. Some are in clinical trial. Right now, the approved drugs are eculizumab, also called Solaris, or ravulizumab, also called Ultomiris, or pegcetacoplan, also called Empaveli. As we said, the first two are C5 inhibitors. The third is a C3 inhibitor. These are IV. The pegcetacoplan is sub-Q, and they're all approved. There are other drugs that are in the pipeline that, you know, they are showing some promise, but they're still under clinical trial. Some of them are inhibitors, for example, factor D inhibitor, which is also part of our complement cascade. You know, it's just basically everything is around the complement system, because our complement system is what's causing the disease. It's what's destroying our red cells. So everything is around how can we control our complement system from destroying so many our red blood cells. Now, this is, I believe, our last slide, or almost our last slide. So I hope you guys are awake. We're almost done. And these are probably the most common questions I get asked. So maybe this will answer some of your questions. Number one, how do I diagnose PNH? So you guys should be more than able to answer this question already, because how do we diagnose it? It's a simple blood test, okay? It's called flow cytometry, plus or minus flare, and we're looking for the surface proteins. Very simple test. Number two, can I stop blood thinners after starting a treatment? And the answer is no. You should not stop a blood thinner. We're learning more and more about these medications, but we know that the number one cause of death in patients with PNH are blood clots. So if you are on a blood thinner because you have had a blood clot, you should not stop your blood thinner unless your physician tells you, because your bleeding risk is higher than your clotting risk. That would be a different situation. But overall, do not stop your blood thinner unless your physician tells you to do so. Another question is, can I become pregnant? Now, this is my opinion. This is something you have to discuss with your physician, okay? With that being said, pregnancy is a hypercoagulable state. If you have PNH and you become pregnant, your chances of developing a blood clot have increased immensely. So, you know, that's where you have to have your discussion about treatment with one of these medications, whichever one you all choose. So I would not discourage a young person from wanting to start a family or have a family, but it's very important that you discuss the risks and the benefit of becoming pregnant while you have PNH and on receiving one of these potential medications while you are pregnant. This is a one-to-one discussion you have to have with your physician. And hopefully, you know, everything in life has a risk. I always give the same example. We hop on a plane knowing it may fall out of the sky, but that does not stop us from going on vacation. So this is a conversation you have to have with your physician and you know, just decide for yourself what's the best option. How can I prevent infections? Number one, get your vaccines. Make sure your vaccines are up to date, especially, I'm going to repeat them, Haemophilus influenza, pneumococcus, and the meningococcal vaccine. Very important. The other thing is, if you develop signs or symptoms of an infection, just know that you are somewhat immune suppressed, so let your physicians know. If you are on treatment with a complement inhibitor and you get sick, do not wait around. Go seek help. And if you feel sick enough that you go to the emergency room, Just don't sit there waiting for the triage nurse to evaluate you. No, let them know you have PNH. Let them know you are on a complement inhibitor, because if you have your immune system blocked and you are on one of these medications, you could develop a life-threatening infection. And time is key. So make sure that you are proactive and you seek medical help and you let everybody know what's going on. Most patients, or all patients that are on these treatments, are given a card, a little card that basically states what they have and what they're on, and it tells the emergency room physician or nursing staff or a primary care, because let's face it, a lot of hematologists are not thinking about PNH. So what do you think of the chances of an emergency room physician or a primary care doctor knowing what PNH is or one of these complement inhibitors is? Chances are they're not going to know. So you give them this card, which will educate them, and then they can take the necessary steps to keep you as safe as possible. And what treatment should I choose? Listen, they're all great. It's really up to you and your physician, the way that your PNH is presenting, how much anemia you have. Have you been on treatment before? Is the treatment that you're on working? Is it not working? Do you prefer IV? Do you prefer sub-Q? But I can tell you they're all good, and you're not going to go wrong in any way that you proceed. I just thought I'd throw this in here. The bad thing is we really don't know what to do with it. So COVID-19 vaccines can induce severe hemolysis in PNH patients. So, just thought for you guys to know, because I'm getting asked this question. We're learning as time goes on. So hopefully we'll have good answers for this. But just know that this has been described. So let your hematologist know. What I would recommend is just to be followed a little more closely. If you do get vaccinated, make sure your LDH, your haptoglobin, that these sorts of things are being followed closely, because this has been described. And I believe with that, my time is up.
Thank you so much, Dr. Roman. We have a few questions. Our first question is danicopan factor D inhibitor. How does it work?
Well, it basically inhibits factor D. That's just basically part of our immune system. If you can go back, I don't know if I have it. Can you see my slides there?
Yes.
Let me see if it's on one of these slides here. Okay, it's not on this one. I don't think it's on this one either. I guess it's in one of my other slide presentations.
And the additional, I'm sorry, Dr. Roman.
It basically, we have several checks and balances in our complement system that tries to keep our complement cascade from not being hyperactive, if you will. So a lot of these drugs, in one way or another, they help keep our complement system in check, basically. That's what the majority of these drugs do, or all these drugs. They either block complement specifically, or they block another protein which has to do with the activation of our complement cascade. But the end result is basically trying to keep our complement system in check.
And the second part to that question, Dr. Roman, was how does this differ from APL2?
This treatment?
Yes,
well,
danicopan.
Well, we really don't know, in the sense that, they're inhibiting different, like APL2 is a C3 inhibitor. So, each one is inhibiting their specific target. But remember that, how does it compare? We don't know. It's under clinical trial right now. I always encourage clinical trials. I always tell patients, if you are on a clinical trial, there's a good chance that maybe you are getting the drugs of the future. If, the reason you are on treatment today is because somebody before you was on a clinical trial with the drug that you are on. How does, so I always encourage clinical trials. And clinical trials, I can tell you for the most part, are very extremely, they're scrutinized, they're very labor intensive. You're having blood tests. Several physicians are looking at this. I can tell you that all the I's are dotted and all the T's are crossed. And I always encourage a clinical trial. But unfortunately, how does it compare? We don't know because it's under trial.
Our next question is there a higher rate risk of infection with a C3 blocker versus a C5 blocker?
That we can tell thus far, I would have to say that the answer is no. Originally, we thought when I first heard of the C3 blockers, I assumed that maybe there would be. But thus far, that does not seem to be the case that we are seeing. In the clinical trials, that really it did not seem to have an increased risk of infection. Actually, it was actually pretty similar to what we experienced with the C5 inhibitors. So the answer to that, the short answer is up to now, the answer is no.
Thank you. Our next question is, how accurate is a peripheral myeloid mutation panel done using peripheral blood sample versus a bone marrow biopsy?
Oh, it's very good. I mean, peripheral blood flow cytometry, make sure that if you've already been diagnosed with PNH, you can have any flow cytometry, but as long as it's a flow cytometry looking for PNH proteins. But the test that we tend to use, and most labs are using now, is a test that's called high sensitivity flow cytometry. So what that does is that it detects clone sizes that are well below 1%. I mean, tiny clone sizes, 0.1%. That's why it's called high sensitivity flow cytometry. You do not need a bone marrow to diagnose PNH. You do not. Peripheral blood is very good. It's very accurate. And if you do a high sensitivity flow cytometry and that test is negative, then you do not have PNH. Now, could you have a tiny, tiny, undetectable PNH clone size? I mean, I guess it's possible, but it would be so tiny that I would dare to say it's not clinically meaningful, at least not at that time. Now, could that clone expand in the future? Yeah, it could be. But that does not mean that a bone marrow would detect it. Absolutely not. Like I said, the bone marrow biopsy would only be indicated or is done to look for a bone marrow issue. But to diagnose PNH, peripheral blood is just as good.
Thank you. What is the risk of PNH reverting back to aplastic anemia versus PNH progressing to MDS?
MDS, in general, you tend to see it more often with aplastic anemia. I've seen both. I've seen patients with PNH develop aplastic anemia. I've seen patients with aplastic anemia later on developing into overt, vice versa. The aplastic anemia presents itself, and then the patient starts presenting more of a PNH picture, or a patient with PNH, and then later on presenting more of an aplastic anemia. So it kind of comes and goes. In general, most patients with MDS do not have a PNH clone. MDS is not that common in PNH. And I actually, when I lecture physicians on this, I actually tell them, if you're going to test every myelodysplastic syndrome patient, you may develop testing fatigue in this. I do not want that to happen. For example, if you start testing every single myelodysplastic syndrome patient, and you start, after your 20th, your 30th patient, and you do not find PNH, chances are you're going to stop testing for PNH. And that's what I don't want happen, because then one day you're going to have a patient that will have it and you'll miss it. So I'm not saying that you need to test every single MDS patient, but just know that MDS can be somewhat associated with PNH. It has been seen with a PNH clone. Absolutely, aplastic anemia patients should be tested for PNH. Number one, because it tends to be at a higher, you tend to have a higher hit rate. So more patients with aplastic anemia, you will find PNH. And number two, if you have aplastic anemia and you have a PNH clone, so let me repeat this. If you have aplastic anemia and a PNH clone, you tend to respond a little better to immunosuppressive therapy, known as ATG and cyclosporin. So it not only gives us a more accurate diagnosis that we know this aplastic anemia patient also has PNH, but it also gives us prognostic information or a possible therapeutic information that you may respond better to immunosuppressive therapy, because one of the main treatments for aplastic anemia is cyclosporin and ATG. So absolutely, aplastic anemia patients should be treated. But as far as presentation, they can present at any time. Remember, every patient is unique, and you have to approach every patient keeping that in mind.
Thank you. Is there a higher risk of clotting with a C3 inhibitor versus a C5 inhibitor? And did Empali show reduction in clots like eculizumab did?
Well, the answer to that question is when you look at the clinical trials, the clotting risk was very low for all drugs, So up to this point, unless something else presents itself in the future, up to this point, all complement inhibitors seem to work very well. They all seem to have, and again, this is my medical opinion, my expert opinion that I'm giving you. If you look at the clinical trials, the incidence of infections, the clotting rate was pretty much equal across the board. Empaveli was compared to on certain aspects to which, I'm not going to get into detail of the clinical trial, but it was compared with patients on Soliris, a specific population of patients on Soliris, and patients were overall the incidence of clotting and infections were pretty much equal. So the answer is no. One does not tend to show a higher infection rate than another.
Thank you. And if a patient were having breakthrough hemolysis and was considering transitioning from one treatment to another, specifically using the Empaveli, how would they go about doing that?
So it's actually quite easy. It all depends if they are on Soliris or they are on Ultomiris. What you want to do, and just, first of all, speak to your physician and make sure that this is something that is appropriate for you. There are guidelines that, especially on the package insert, which explain how you can transition from one drug to the next. And basically what you're going to do is let's say, for example, you are on Soliris. You're going to stay on Soliris for a few weeks while you start Empaveli. And then after a few weeks, I believe, if I remember correctly, it's all in the package insert. After about 4 weeks, you are going to stop the Soliris, and then you will remain on the Empaveli arm, on the Empaveli treatment, and then you will monitor for hemolysis. That's basically, so you're not going to stop one drug cold turkey and start the other one. No, you're going to start both of them, right? Just continue the one you're on. You're going to add the other one on. And then if you look good and your labs look good and you're tolerating the drug and a few weeks have gone by, I want to say it's 4 weeks, then you can stop your prior treatment and stay with the new treatment.
Thank you so much, Dr. Roman, for sharing your time and your expertise with all of us today. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, please send it to us at any time in 3 ways. Send an email to our help account, which is help@aamds.org. Call our helpline at 800-747-3233. 2820, extension 2, or you can submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to help support you and your family, as we've done for the past 37 years. This concludes our program today. Thank you again, Dr. Roman.
Thank you. You're welcome.